All right, today we're going to dig into a really interesting study that might just change how we think about localized prostate cancer. The big question here is, can a new AI tool, when you test it against some seriously high-quality data from a landmark clinical trial, actually give us a better look into the future for our patients? Let's get into it. So here's how we'll break it down. First, we'll talk about the problem clinicians are up against every day. Then, we'll look at the AI biomarker itself. After that, we'll dive right into the results, and they are pretty powerful. But then, and this is key, we're going to take a step back and critically appraise this whole thing before we look ahead to what it all means. Okay, so let's start at the beginning, the core challenge that we face in the clinic. Why does this kind of research even exist? Well, it's all about the tricky business of sorting patients into the right risk groups. And that leads to this fundamental question, right? For years, we've been using the same tools, but we all know they're not perfect. The dream is to get a much sharper, more personalized picture of a patient's actual risk, because we know that getting it wrong can have huge consequences. Our current systems, things like the NCCN risk groups, they're really built on these three classic pillars. You've got the PSA level, the Gleason grade group from Pathology, and the clinical T stage. These have been the absolute bedrock of how we make decisions for a very long time. But, and here's the big but, we know these factors just don't tell the whole story. They can't fully capture the incredible biological diversity, the heterogeneity from one tumor to the next. And that knowledge gap means we sometimes end up overtreating some men and, just as concerning, undertreating others who really need more aggressive therapy. This is exactly the clinical gap that new tools are trying to bridge. Which, of course, brings us to the tool at the center of this study, a new AI-powered biomarker. So what is this MMAI biomarker exactly? Now, it's really important to get this right. It's not just a fancy image analyzer. It's multimodal. That means the AI algorithm looks at a massive amount of visual information from the standard H&E pathology slides, and then, this is the key, it combines that with the clinical data we already have, like PSA, age, and stage, to spit out a single, unified prognostic score. Now, what makes this paper so compelling is the data they use to test this thing. We're not talking about just any old data set. This is from the CHHiP trial, a massive, randomized phase 3 study. They analyzed slides from almost 1,800 patients. And get this, the median follow-up was over 14 years. That is an incredibly robust, high-quality cohort, which gives the findings some serious credibility. So, how does it work for a given patient? Well, it's actually pretty simple in concept. The AI scans the digital biopsy slide, it pulls in the clinical data, and then it puts that patient into one of three buckets: low, intermediate, or high risk. The whole point is to create a more nuanced risk stratification than what we have now. Okay, so we've got a smart tool and a fantastic data set. Let's get to the main event, the results. How well did this AI biomarker actually predict what would happen to these men over the next decade and a half? Let's start with this number, because it's a real headline grabber. 5.07. That's the hazard ratio. What does that mean? It means patients that the AI put in the high-risk group were over 5 times more likely to have a biochemical recurrence, a rising PSA, than the guys in the low-risk group. That is a very strong prognostic signal. But honestly, it gets even better. Because predicting a rising PSA is one thing, but the AI also did a great job predicting the development of distant metastases. And as we all know, that is a much more clinically meaningful, hard endpoint. It's what really impacts a patient's life and ultimately their survival. And this table here really shows the value add. This is the C index. Just think of it as a score for predictive accuracy, where 0.5 is basically a coin toss, and 1.0 is a perfect crystal ball. You can see that when you take the standard models like CPG or NCCN, and you just add the MMI score on top, the predictive power for distant mets takes a pretty significant leap. That tells you the AI is seeing something in the biology that our standard clinical factors are completely missing. So yeah, the results look really impressive. But, as clinicians, as scientists, this is the point where we have to put on our critical thinking hats and apply a little bit of healthy skepticism. So let's really appraise this work. So before we think about bringing a tool like this into our clinics, we have to pause and consider a few major things. First, this is a retrospective analysis. A very well done one, but retrospective nonetheless. Second, and this is the big one, this study shows the tool can predict risk, but it doesn't prove that using the tool to make different treatment decisions will actually improve patient outcomes. And third, there are the practical, real-world headaches of just integrating this into a busy pathology workflow. And this right here, this is the absolute bottom line. It's the most important takeaway. A prognostic biomarker is only really useful if it helps us make better decisions that lead to better outcomes for our patients. And that part, well, that still needs to be proven. Okay, so we've got these really promising results on one hand, and some very important limitations on the other. So where does that leave us? What's the path forward from here? To put it simply, here's where we stand. We now have really solid evidence from an excellent data set that this AI tool can significantly boost our ability to predict risk. What we need now, the clear next step for the entire field, is to get prospective data that proves using the tool actually changes things for the better. But the potential here is just huge. I mean, if this technology pans out in prospective trials, it could really help us personalize therapy in a way we've only dreamed of. We can more confidently ramp up treatment for the guys who really need it, and, just as importantly, we could help other men safely avoid the side effects of treatment they never needed in the first place. And so we're left with this final critical question. This study is a huge, exciting step, but it's not the final step. The question on everyone's mind is no longer if AI is going to have a role in our clinics, but when. When are we finally going to see the prospective data that solidifies its place in our daily practice?